The system meant to support a healthy America is trying to cut the funding that makes home health care possible. And if they succeed, it's your parents, your neighbors, and maybe even you who will feel it. We're talking today about what those proposed payment cuts are, why they're happening, and how we ended up here. But more importantly, we're talking about why home health care works, why it matters, and how we can protect it. So let's talk about what happens when you treat home health care like a budget line instead of a lifeline that helps real patients and families. To set the scene, on June 30th, the Centers for Medicare and Medicaid Services, or CMS as we know it, released the calendar year 2026 home health proposed rule. And as we know very well, the potential impact is absolutely devastating for patients, families, the home health community. So we're going to get into that today. But let's back up a little bit first and talk about what is the Medicare Home Health Benefit? How does it serve patients and families?
I'm glad we're talking about home health and the Medicare Home Health Benefit. Not happy that we're talking about this proposal because, as we'll get into it, this is a terrible idea to cut payments to home health by this much. It's just not tenable. It's going to hurt people, and we're going to get into some of that. But, big picture, the Medicare Home Health Program, it's critically important to the function of the health system and of the Medicare system. We're talking about services to, about 3 million people every year. This is a program targeted to people that are homebound. It's the only program that I'm aware of in the Medicare system where it's focused on people that are homebound. So, what does that mean? I think there's about 2 million people actually in Medicare that are persistently homebound, like they just don't leave the home because of their medical condition. And also, maybe up to 5 million people that are semi-homebound, have sort of bad days, bad weeks, bad months where they need the help of other people and they struggle to leave their house. So if you're in that situation where you can't readily leave your home and you need nursing services or you need rehab, like therapy services, the Medicare Home Health Benefit is the way to do it. A lot of times it's being used to help people recover from hospitalization. So it's pretty common. Maybe somebody's been hospitalized, had a surgery, had a some type of medical issue. They can't go home without help because they would just go right back to the hospital. They need too much support. The Medicare Home Health Benefit would provide those nursing therapy services. Also, maybe let's say somebody was hospitalized, but then they were in a post-acute facility and still their care is just so complex and there's so many needs and they eventually can get home, but they need help at that point. And so that might be a time. And then, sometimes, what I like to see happen is before people have to go in the hospital in the first place, if, they're starting to decline or something's not going well, if we can rally help at home before things go bad and prevent that hospitalization, and home health can be used in those scenarios also. So you can imagine, like, if you can't get out, maybe you've had a stroke or you have very serious musculoskeletal disease, or you have trouble breathing and need, oxygen concentrator and get short of breath easily, or maybe you have dementia and neurological issues and thinking and in the issues of leaving the home are just really, really scary and dangerous. This is what helps you stay home or allows you to be in your home. Otherwise, you're going to be back in an institution. And so that's what we're talking about here with this Medicare Home Health Program, critically important.
It's interesting when you talked about preventative health, because I know CMS is focused on that right now as a really important thing to help support Americans continue to age healthily or just live independent lives, continuing to contribute to the communities. So we know home health can uniquely do that. But let's talk about these proposed cuts and what the impacts could be. So I know over $1 billion of proposed cuts in 2026 alone. What's in this proposed rule for 2026 for home health agencies?
Yeah, again, the administrations, they have proposed, it's not final yet, but they have proposed, we don't want to let it become final, quite frankly, the way it is. They have proposed to cut 9% or, over $1 billion out of home health payments. This program isn't that big. I mean, it's you take this much out, people are going to feel it. They're already feeling it because this has been part of a cycle of adjustments. We've seen agencies close. We've got, over 1,000 less agencies than we had in 2019. Home health agencies is what I'm referring to. That's who does this work. The home health agencies provide those nursing and therapy services. We're seeing delays in care. So people are getting care later. The delay right now that we've studied is that it went from about 2 days for people to get their home health when they left a hospital setting in 2019. As of late last year, that was already up to 3 days because access is declining. And also, there are people that are getting referred for the care that don't even get it at all. So not even the delay. And that actually is, we talked about this, I think, earlier, that's been shown to be associated with higher mortality. Like people, if their doctors think they need home health when they're coming home from a hospital and they don't get it, people die. It's really, really serious. So, what's happening here is that CMS is implementing some home health payment reform. There was, starting in 2020, there was a directive to begin this home health payment reform initiative. It changed some aspects of how home health was set up, but it was never intended to be a cut. That's the crazy thing here, is that it was intended to change to 30-day periods of care, to change how some of the payment algorithms work, but it was supposed to be a stable modernization of the program. But what we're seeing, inexplicably, quite frankly, is CMS marching forward with draconian cuts to the program.
What are the potential impacts if those cuts are implemented? So we already know that we're seeing issues with patients getting access to timely home health care now. What would happen if payments were further reduced for home health agencies, for patients and families, and also for those providers?
Oh, well, we're going to see people not get care. Like, there are going to be people that are going to need the care, and particularly if they live in rural areas or they live in high poverty communities that are harder to serve for some reason, they are going to be even more at risk for not getting care. Agencies are going to have to cut back. We already know of providers that have had to withdraw from rural communities and other vulnerable areas. So people aren't going to get the care. Like we said, that's a life and death issue. So sadly, there could be some people who die because of the not getting the care they need. We're going to see more delays in care. We'll see more agencies close. And also, here's the ironic thing. Like, so, we talk about this being a budgetary issue rather than a patient-centered issue. This is not going to help any government budget. Okay, when people get home health, it's less expensive for the system. It's an alternative to them going back to the hospital, which is way more costly. It's an alternative for them needing to be institutionalized, way more costly, needing to use the emergency room because things fall through the cracks, way more costly. Home health is like the lowest cost care setting in lowest cost care model. So it makes no sense. Why would we undercut something that is low cost, high value, preferred by people? That's the amazing part, is that even though it's lower cost, it's preferred. People want that independence, that autonomy they get to be able to stay in their own homes. And here we are cutting it. Yes, we're going to see delays. We're going to see people not get the care that they need. It's going to be worse in rural and vulnerable communities, and it's going to cost the system more. It is just all across the board, from top to bottom, bad policy. It's just bad policy. I don't like, we're supposed to have interesting conversations here and like talk about, oh, well, what about this side of it? And what about that side of it? It really is just not well thought out.
From what I understand, it feels like the hope is that there will be, funds recouped. But like you said, it saves the system money to put patients in home health care. And if these payment cuts cause further closures in home health agencies, which is what's anticipated, and some home health agencies might need to turn patients away. If they don't get out of business, they can't support, because they don't have the money to pay for staffing. They can't support all these patients. So patients are going to get turned away. Home health agencies are going to close. Patients that do get care will have to wait longer to get it. All of that does cost the system money. And so maybe it's like a short-sighted attempt to cut now, but we know that immediately we'll see those costs rise and we will not be saving the system money at all. So if we know that even in the short term, the costs are going to rise for the system and the outcomes will be worse for patients and families, why would CMS propose these cuts? Like, what are they thinking? How do they misunderstand the home health program?
I hate to be one of these people that just kind of throws their hands up and says, this is bureaucracy, sort of example of, bureaucracy run amok. And it really appears to be that way. So basically, Congress had required that Medicare, the officials, and these are public servants. I don't want to call people, in a pejorative way. They're trying to get it right, but the Congress instructed them to re-envision the payment system, moving from 60-day periods to 30-day periods, changing how physical therapy services contribute to the payment calculations. But it was supposed to be done in a way that wasn't a cut. It was budget neutral. When Congress can take credit for a cut, they like to use those savings for other things, like they pass them on for tax cuts, or they use it to pay for another pet project. When they did this home health legislation, none of that happened. They didn't think they were cutting anything. But the way that the officials at CMS have interpreted this, and they've gone with, they have a data contractor that they're working with, and they've gone through all these machinations and methodologies. Actually, it's not all that transparent. So there's a little bit of a black box here, which is really frustrating when you don't get all the details of what's going on. But they came up with a methodology to implement what Congress told them to implement, and the output of it is leading to cuts. It's leading to these and it's not just this year. Actually, we've had some smaller reductions over the last few years. This proposed 9% is just so much bigger and so much more devastating, quite frankly. And there's an aspect where these officials, they want to make sure in their own minds that that they're not overpaying, okay, that they're not paying exorbitantly more than what it costs to provide the care. But what we know is when we look at home health agencies using Medicare officials' own data, already almost 40% of them in 2022, 40% of home health agencies already had negative margins. Okay, when in this weaves in and out of some of the talk and some of the comments you'll hear here is CMS will say, well, some of the home health agencies have high margins and our margins an issue. But when we look at the whole Medicare program, we look at serving the traditional Medicare population, the Medicare Advantage population, Medicaid beneficiaries. There aren't much in the way of margins. Agencies are negative margin or very low margin. This will be incredibly destabilizing. One other thing I want to go back to about those methodologies that's important, because they haven't given us the details of all aspects of those. There appears to be a chance that they've included some obvious examples of fraudulent home health providers within the way they calculate the methodology. So it's possible that when they went through the methodologies to the process to develop the new payment system, they included data from hundreds, if not more, home health agencies, particularly in LA County, where they've had a hard time controlling healthcare fraud, that they might have included data from these fraudulent agencies in the process. So what we've asked them to do is go back to the drawing board. You obviously haven't done what Congress asked because, again, millions of less people being served, tens of millions of less home visits over these many years, closures, delays, people not getting care. It's not what Congress wanted. Something's wrong in these methodologies. What did you get wrong here? And also, did they include fraudulent data? That's one of the issues we want them to reevaluate. It's not fun to talk about. It's not, it's a problem.
Yeah. And I know we're going to talk more about fraud, waste, and abuse because it's important for us to touch on that. But we've talked about how home health care saves the system money. So it reduces the costlier institutional setting, emergency department visits, can lower mortality rates. Obviously, that's good for the system, but let's focus again on why it's good for patients and families. So why do people prefer to get home-based care?
The healthcare system, listen, even I've been healthy, it is monolithic, okay? We work in it. We admire the work being done, but it feels sometimes like you don't have any control. In your own home, you're in control. It's your home. It's your family's environment. You choose how things go, and it's familiar in your near family. The healthcare institutions are wonderful. They're some of the most compassionate and humanistic places in the world, but you don't want to be there if you don't have to be there. It can be dangerous also, right? There's the possibility, we saw what happened during COVID. in long-term care. Any type of infection can run through a hospital or through a facility, especially with, people with weakened immune systems and lots of diseases. You can get, older people, particularly that have dementia or cognitive impairment, can get their days and nights mixed up with all the lights going off and the sounds going up. You can get delirium. There's something called delirium, or becoming delirious, which is actually a life-threatening complication of being in a hospital. So, there's so many reasons why people prefer to be at home. And it's an act, like, it's truly an act of humility. It's one of the ultimate signals of a compassionate, caring society, that we care enough for people, that they mean enough. They're not just a number. It's not just get in line at some place that you got to have an ambulance drop you off at. It's your home. We care enough about you to come see you on your own turf and provide you that care. And listen, people's homes, it means so might, if they live there a long time, it might be where they raised a family. It might be where I've had patients, that I saw at home tell me, I'm laying here in this bed and this is where my husband passed away, and I cared for him in the past, and I want to stay here. I don't want to go to a facility. I don't want to have to be, institutionalized if I don't need to. It's preferred. It is often safer. It's lower cost. So this is where strategically we should be focused on building up, not cutting back.
Yeah, I think the most profound thing, I mean, the potential medical complications that you touched on, that's illuminating. But I think the most profound thing about what you said is just that's where people want to be. Why wouldn't we support a system that enables that? And even for the simplest reason of like, oh, you get to be at home and continue making memories with your loved ones. If you're recovering from an illness, you can integrate back into society faster, kind of get back up on your feet. If you're, working remotely, even like you can stay at home, you can situate yourself and your life can be more normal as things carry on. And there have to be outcomes that are impacted by that. Like if you are happier and you're in a better setting, then you probably do recover faster. Like I don't know what the data say, but I know just anecdotally speaking that seems to be true. Who wouldn't want to be recovering at home versus an institutional setting?
There's some evidence behind that care period is shorter when we can care for people at home, with acute care, for example. But like you said, it's also for the caregivers, like family caregivers. Now, when people are at home, family caregivers have a lot of responsibility often. It can be hard. It can be burdensome. Sometimes it just doesn't work. If people don't have family or there's not enough support there, it doesn't work. But also for families, when their loved ones are in a hospital or in a nursing facility, it's also incredibly stressful and expensive. Just in the transportation and transporting somebody who's disabled and has challenges back and forth is expensive. It can be burdensome. It's a real lifeline for families and for seriously ill people with mobility limitations. It's absolutely what we should be focused on as a country that has an aging population, as a country that has. This is not about we're pushing back on a proposed payment cut, in understanding that we do have a country that has expensive federal programs, right? That we do have to worry about debt and deficit issues as a country to be prosperous and to, but home health is a tool to lower spending in a way that people prefer. It's like a win-win. It's one of the things that you use to that policymakers can use to not lose votes, because they care about that. They want to get reelected. Folks, if you want to come back to Congress, this is a kitchen table issue for you. If you want to come back to the White House, this is what families are talking about. They are around their kitchen tables, their family conversations, talking on the phone with their loved ones, maybe their sister that moved, across the country, about how we're dealing with the challenges that mom and dad are facing. And home health is a solution that they all love, need, want it to be stronger, need it. And it also keeps people out of much more costly types of care. So if we're going to succeed and have happy families and people that get their health care that they needed, and we're going to have politicians that are respected by their constituents, and we're somehow going to keep the federal budget in some type of shape. This is where we should be focused. This is not the thing to cut. Get out of here. This is crazy.
Let's double click on that. So I think it's clear that they're misguided, right? But how would we direct CMS and then legislators to act? So on the one hand, we're going to ask CMS to obviously pause these cuts that can reevaluate the methodology. What else are we asking them for? What do we want? And then on the other hand, assuming that we're still pursuing that CMS change, what are we asking legislators to do in the meantime? We want to make sure that we're not in a situation where under any circumstances these proposed cuts become implemented.
Well, we're telling them that we're in an open comment period. Okay, when Medicare or any federal agency puts out these proposed, rules, you're in a period where you can provide feedback. Okay, that's part of our democracy that seems to still work. I'm hoping that it works. We are trying to maximize the voices heard during that comment period. All right. We are pushing everything we can in terms of the data about the cost savings of home health, the implications of not, having good access to home health in terms of the cost of care and the people's overall health. We're making sure they understand this issue that they seem to be overlooking around the fraudulent data being incorporated in their methodologies. It doesn't make sense why they would overlook it. Dr. Oz has been very forceful on addressing fraud, waste, and abuse issues early in his tenure. So we know this is a priority for his. We need him and the team to zero in, address some of that waste in the system.
It seems like they know what's going on in LA County.
Yeah, well, the news, we keep getting news clips about, providers that they're investigating. They just had an article in the Los Angeles Times looking at, fraud in that region. Like, why don't we get rid of that stuff rather than the good stuff and figure out, did you do something wrong? Was there something in the last administration when they made these, adjustment formulas that they got wrong? Time out, stop this process. They have full authority to do this, by the way. What we're saying, like when we say hit the stop button on this and reevaluate, they have in the law the full authority to do this. They don't need an act of Congress to do this. Now, that said, we're concerned because they put this forward and we can't just assume that they're going to take it back. And so we are going to work with members of Congress to try to, backstop this and insist that they, legally insist that they don't go forward if they continue down this road. What else can you do? There's a lot of other things we should be focused on. I mean, one of the important things, we've talked a little bit about technology in healthcare. And so the use of telehealth could be really important to more efficient and more accessible home health. Okay, you've got workforce shortages. People are really sick now that are in home health. We need to respond quickly, triage issues like instant. We find out somebody is weak or they're having a breathing issue or they're not sure about their medicines. Let's jump on telehealth even before the nurse or the therapist gets out to their house and start to address those things. The laws and regs actually don't allow for that to happen very well right now. So there's some modernization that we could be focused on. So yeah, don't cut the program. It makes no sense. Let's focus on modernizing it, better use of technology. Let's address these fraud, waste, and abuse issues. There's so many better things to be working on than this.
Yeah, and even addressing the appropriate reimbursement rates would mean that providers can staff up. I mean, they have to compete with care provided in other settings and the wages that nurses and other home health care workers would be paid in an institutional setting in a hospital, and they just can't compete. I think I saw something about the payment updates in other areas beyond home health care. And home health was absolutely dwarfed by the payment updates in other areas. So how is home health going to compete when they're already in dire straits and they're only going to get worse? We need workforce in order to care for these patients and families. And so we're already in a bad spot, and we're only going to be in a worse spot if we don't address these potential cuts.
Yeah, workforce. It's if you spend any time with people that are concerned about caring for seriously ill people, older people, people with disabilities right now, the biggest concern everywhere across the board is workforce. Are there enough people? Do we have enough skilled and trained people to address the needs of the public? And, again, we've got demographic issues. We've got a rapidly aging population. The younger population is not growing that fast. And so, it's a numbers game, and we're not training enough new nurses. Nursing, we need to build that pipeline. It's not there where it needs to be. So you've got all these workforce challenges. And, one of the things that I want to remind everybody, because then, people, well, what should we do about workforce? And what's the workforce policy? Payment policy is workforce policy. Okay. Reimbursement, that is when the agencies, home health agencies, get reimbursed by the government. That is the purchasing power for them to recruit and retain these incredible people that do this amazing work. I remember my dad had, I'm smiling a little bit, and I'll get to why I'm smiling. My dad has had 2 strokes, and he's partially paralyzed from these. And the second time, when he came home from a rehab facility, he still was struggling to walk, struggling with the basics of life. I don't want to get into the details of it, but struggling to talk, swallow, eat. And his physical therapist that came out and helped him, and now he's back. He's more independent now. He can go places. He actually plays in an adaptive golf league called the Strokers, which is a group of stroke survivors that play in this adaptive golf program. So he got recovery, but his therapist, who was amazing, and she bonded with Scout, their golden retriever, who's like my parents' favorite child. Like, I'm very far down the list from Scout. But this person, that's what the money's paying for. Okay, the people like that are going out on people's darkest moments of their lives, that are trying to come up with ways to bond and connect with families, like, even hugging Scout, who's I'm jealous of him as my younger brother, that he gets all the attention from my parents. But that's where the money goes. And so when we talk about a cut, what we are talking about is cutting the workforce. Okay, this is just going to make it harder for home health agencies to retain talent. They're already, just by headlining this kind of cut, there are employees of home health agencies that are saying to themselves, what am I doing? Is this right? What's going to happen here? What's going to happen in my workplace? What's going to happen in my company? What's going to happen in my job? And so reimbursement policy is workforce policy. A 9% cut to a system that is already under stress is going to lead to devastating loss of talent and access. People will suffer. People will die. The system will spend more money because people are going to be rehospitalized. Hospitals and medical facilities are going to struggle with throughput. Okay, getting people out. We already know that's an issue in many communities in our country. People, the hospitals don't have access to post-acute care. So people stay a day, 2, 3, 4, 5, 7 extra days in the hospital. Then they didn't need to be there because they don't have access. They don't have a safe discharge plan. Hospital doesn't have enough beds, enough available beds. People back up in the emergency room. Emergent procedures are delayed. You've heard stories of, people in their 80s, 90s, and beyond laying for 2-3 days in a gurney in an emergency room instead of getting the type of care that they need. I mean, I know you're from Massachusetts, Elyssa, and in Boston, this type of has been a real concern amongst the hospitals there, but also, American Hospital Association has brought this up as a national issue. So, there's a better way to go about this.
Yeah, it seems like the picture is crystal clear. So I know what we're working towards with both CMS and on the legislative side. We don't want to be in the business of predictions, but I've heard some people talking about, well, in the past, they've rolled the cuts back from the proposal to the implementation or the final rule. Do we have any idea what's going to happen there? I know the Alliance is working tirelessly to make sure that these cuts are not implemented. But if you had to predict what's going to happen, do we have any sense of where things go from here?
I think that when they show that this is what they're planning to do, I believe them. All right. Until until proven otherwise, until they come out and say, I mean, they can issue an emergency revision to this right now. Okay, right now is as we speak, Administrator Oz can revoke this proposal and put in place a more thoughtful proposal. So until somebody does that, until it's fixed, I believe it, and I think that we have to do everything we can. Advocates for homebound elders, advocates for people with serious chronic illness, concerned about people with, stroke and that need orthopedic surgery, and that people that have had cancer and have ongoing treatment needs and are low mobility from from their medical condition, heart failure and chronic lung disease, and all the things that cause people to need care at home. If anybody that cares about those folks needs to speak up right now, because until there's some type of mitigation here or some type of alternative that's put forward, no, I'm not going to predict what's going to happen. I don't trust the judgment that was used to put out this rule. I don't know what was the thinking that went into this, but until somebody shows that they're applying some new thinking to this, I'm not predicting anything other than reminding everyone that we need to speak up, tell the story, tell the incredible, life-changing, value-creating story of home health, and remind everybody what they're messing with here, because this is bad policy. It's bad for seniors. It's bad for Medicare. It's no way to run Medicare.
And I think the home health community and like you said, the broader home-based care community is pretty united in this stance. I mean, everyone understands how dire the consequences would be. So I think just reminding everyone, like you said, to get involved in advocacy efforts. The Alliance has a grassroots program. If you go to our website and go to the advocacy tab, you'll see we'll have plenty of calls to action for those grassroots advocates. We have a Hill Day coming up in September 8th through 11th. If you want to get involved, come share those stories of the good that home health is doing. Yep. And then I know we'll be continuing to work with home health providers on how they can activate at the local and regional levels, because we absolutely need to be pushing until we can get this reversed or until further action is taken.
That's exactly right. Everybody needs to voice their opinion. We need every home health agency, every state association that's involved with home health to formally comment, to put those letters into Medicare, to op-eds, social media work. And then, it'd be great to have people at our Advocacy Week events in Washington. That's going to be really important. Getting to face-to-face, sit with the policymakers in Washington and share. I got to tell you, I've been involved in this advocacy work for 20 years, and I've had a chance many times to sit in front of policymakers and talk about issues related to care at home, about hospice, home health. When you get the chance to talk to people, the vast majority of them, they start to get it. You see the light bulbs going off. This isn't that hard. This is not that hard to understand. It's a serious issue. And I do believe that if those voices are raised, if we're forceful here, that something better has to come than what's it. But it is the one thing I would caution everybody, in that you'll see if you come to that advocacy week and you go on Capitol Hill, one of the things I'm noticing is, wow, is Capitol Hill teeming with people. So you want to go in the Senate office building and meet with your senator, or the House office building, the Rayburn House office building, or the Hart Senate office building, and you want to go meet with your representative. When you show up in the morning, get in line, right? This is like if you think the line to get into Disney World is long, wait until you try to get into Congress or even the White House offices. Okay. Yeah, absolutely. I guess, it's a beautiful place, but the line is long, and the line to meet with our elected officials is long. And a lot of people are trying to influence Congress. And so I think the biggest risk that this doesn't get fixed is that our voices get drowned out in this sea of everybody else trying to talk. And there's hundreds of issues, right? We have issues around education and, foreign policy and our economy and manufacturing and pharmaceuticals and everything you can think of. Somebody's coming to Washington to try to talk to their members. So we have to show up in numbers. We have to be bold. We have to do it multi-channel, across social media, op-eds, editorials, show up in the district offices. Actually, I've heard that getting in to see a member of Congress in their district office sometimes is a little bit easier, or at least with their staff. Yeah, you get an August recess and can visit back home. But we've got to speak up.
Yeah, I think that's the perfect note to end on. There really isn't a high note. I mean, this is absolutely potentially devastating. Make sure your voice is heard. This is the time to act.
No question. We step up, speak up, and let's insist that this gets fixed. This is a bad proposal.
Next time, we're digging into Medicaid and something called HCBS. If you haven't heard of that before, don't worry, we've got you covered. We're breaking it down in simple terms and showing how this program can make a huge difference in the lives of those who need it. You definitely don't want to miss it.